Start live na? Now already live hai? আচ্ছা অসুবিধা নেই, মুখে মুখে বললে এত বেশি ইয়ে করলে পড়ে যাবে। হ্যাঁ হ্যাঁ এবার ঠিক আছে, একটু ঠিক করলে বলো। অ্যাপ্রুভ হয়েছে?
চলে আসছে।
এরপরে যখন স্লাইড দেখে তো তখন তুমি ইয়ে দিবে।
ঠিক আছে না? Assalamu alaikum. Hello, welcome to all of you to today's class. Today I am going to discuss about medicine. Today our topic is peptic ulcer disease. Now I am going to discuss about the topic. So hope you all are well with staying home and stay safe. I am now start my class. Today our topic is peptic ulcer disease. It's the most important topic in Okay. Today my topic is peptic ulcer disease. I am going to discuss about the topic peptic ulcer disease. It is the most important and common case in our medicine ward. You have to face this case whenever you are in ward and you are in exam. So I am starting my class. At first, what is peptic ulcer disease? Peptic ulcers are chronic and most often solitary lesions that occur in any portion of the gastrointestinal tract that exposed to the aggressive action of acid peptic juices. At least 98% of the peptic ulcers are either in the first part of the duodenum or in the stomach in a ratio of 4:1. And other side, except the first part of the duodenum and stomach, other side of the peptic ulcer diseases are esophagus, pyloric channel, duodenal loop, jejunum, and rarely in the mucus diverticulum. And rarely mucus diverticulum, because after surgery mucus diverticulum is the most common site. Other than mucus diverticulum is rarely involved in peptic ulcer diseases. So next, going for pathogenesis. I don't want to discuss about the broadly about pathogenesis. Just in a brief, I want to say that peptic ulcer disease is due to results of some aggressive factors and some defensive factors. Now, what are the aggressive factors? Aggressive factors are the gastric acid, pepsin, that is are the aggressive factors, and defensive factors. Defensive factors involved in the mucosal resistance, that is gastric mucus, bicarbonate, microcirculation, prostaglandin, and mucosal barrier. And the most important effect of H. pylori, that is Helicobacter pylori. That is the most important thing about the peptic ulcer disease. We are going to discuss about it later. Now, next slide, we are going to discuss about the causes and risk factor of peptic ulcer diseases. So, the most important causes peptic ulcer disease is H. pylori, that is Helicobacter pylori. What is Helicobacter pylori? Helicobacter pylori is a gram-negative organism, that is motile organism, and it is spiral. It produces urase, that is urase-producing organism, and it mostly colonizes in the gastric mucosa, gastric antral mucosa, mostly antral mucosa. And H. pylori is invariably associated with histologic evidence of active and chronic gastritis. So that's why it is very important to treat H. pylori, because if we do not treat it at the appropriate time, it may turn into atrophic gastritis, and ultimately that leads to gastric cancer. So for this reason, we are trying to treat H. pylori, and H. pylori is the most important cause of gastric peptic ulcer disease. What are the other causes of peptic ulcer disease? Except H. pylori, the other causes of peptic ulcer disease, there are some other causes like non-steroidal anti-inflammatory drug. We all know about non-steroidal anti-inflammatory drugs. And then after that, smoking is the most important factor of peptic ulcer diseases. Smoking is another important factor, and NSAID, drugs, NSAID and smoking. So these are the causes of peptic ulcer diseases. And now go for pathophysiology. What is the pathophysiology of peptic ulcer disease? For your clear conception, pathophysiology is needed. Peptic ulceration is strongly associated, as I said earlier, in peptic ulcer is strongly associated with H. pylori infection. Around 90% of the duodenal ulcer and 70% of the gastric ulcer patients are infected with Helicobacter pylori, and the remaining 30% of the gastric ulcers are due to non-steroidal anti-inflammatory drugs. Now, in short, pathophysiology of peptic ulcer. What happened to the disease process? At first, there is depletion of the antral D cell. There is depletion of, I repeat again, and depletion of antral D cell, and increase gastrin release from the D cell. Whenever there is depletion of D cell, then increase the release of gastrin from the G cell, and increased gastrin release in turn causes increased acid secretion, that is hydrochloric acid secretion, and this acid load in the duodenum causes gastric metaplasia and ultimately leads to inflammation and ulceration. So this is the basic mechanism of peptic ulcer diseases. Now, for our prospect for clinical case presentation and for case discussion, the most important thing is clinical feature. So whenever we go to the ward, we found so many patients with peptic ulcer disease, and the most important, you have to differentiate from other diseases from peptic ulcer disease. So you have to you have a brief idea about the clinical feature. What are the clinical features? The most important clinical features, so there are three important features that are the main top important criteria. That is site of the pain. We all know about the Socrates. From Socrates, we know that site of the pain. Site of the pain. What are the site? The site is in the epigastric region. That is most important for peptic ulcer diseases. If the pain is in the epigastric region, you have to suspect about peptic ulcer disease. If the pain is other than epigastric region, then there may be other cause. So at first you have to, whenever patient complain about pain, you have to localize the site. That is, if it is localized to the epigastrium, then there is a more chance to develop peptic ulcer disease. After that, the next point is related to food. Peptic ulcer disease is invariably related to food. And the third important feature is episodic. Episodic means there is a periodic pattern, periodicity. So patient came, pain, and after that remission, and thereafter again pain. And usually we found in our ward, what is the peptic ulcer disease, that all are chronic cases. That is, there is episodic pain in patient came due to chronicity of the pain. So this is the most important feature this is the most important clinical feature. Next, if we differentiate duodenal ulcer to gastric ulcer, for duodenal ulcer, the important clue is pain usually burning in nature, and pain usually persists 90 minutes to 3 hours. Often pain is nocturnal, and pain usually relieved by food. The next one is gastric ulcer. What are the clinical features of gastric ulcer? For gastric ulcer, burning epigastric pain and associated with anorexia, weight loss and vomiting. These things are important for gastric ulcer. Vomiting is important feature for gastric ulcer. In duodenal ulcer, vomiting is less common, but in gastric ulcer, vomiting is common. And one thing is most important, that in case of gastric ulcer, there is a complication. We know that gastric outlet obstruction. In that case, what happened? There is a projectile vomiting. So it is an important feature. You have to ask about the vomiting and nature of the vomiting and content and timing, all that, whenever you take history about vomiting. So there is a anorexia, weight loss and vomiting. These are the important feature for gastric ulcer. Next one is, how can we diagnose a case of peptic ulcer disease? The most important investigation for diagnosis of peptic ulcer disease. So if it said that investigation of choice, that is upper endoscopy of upper GIT, that is upper GI endoscopy. In earlier we done some other investigation like upper barium endoscopy, barium X-ray and other etc. But nowadays the investigation of choice is upper GI endoscopy. And gastric ulcer upper GI endoscopy is preferable to exclude possibility that ulcer is malignant. Blood cytology biopsies are not sometimes needed, but most you just remember the one thing, that choice of investigation of choice is upper GI endoscopy. What are the other investigation? We also need some other investigation for detection of H. pylori. For detection of H. pylori, there are lots of investigation. Some are invasive investigations, some are non-invasive investigations. What are the invasive investigations? Invasive investigations are endoscopy of upper GIT along with histology and culture. And another invasive investigation is rapid urase test. And now go for non-invasive investigation. What are the non-invasive investigation? This is the most important question for your written also. What are the investigation for peptic ulcer diseases? So what are the non-invasive investigation? Non-invasive investigations are serological test, urea breath test, stool or fecal antigen test. Among these, urea breath test and fecal antigen test are more sensitive and more specific. So these are most easy to done, and this is the most sensitive and most specific investigation. Now the most important part is management. What is the management? How you can manage a case of peptic ulcer disease? Regarding management of peptic ulcer disease, at first, what are the aim of the management? Our aim is to relieve symptoms, to induce healing, to prevent recurrence, and to prevent. So these are the aim of our management. Now for management plan, what we use, before going to discuss about the management, that I'd like to discuss about the indication of H. pylori eradication. What is the H. pylori eradication? There are some definite indications for Helicobacter pylori eradication. That is peptic ulcer, extranodal marginal lymphoma of MELT type, that is meltoma. Another name is meltoma or some kind of lymphomas. If there is a family history of gastric cancer, if there is a previous history of resection of gastric cancer, if H. pylori positive, there is a history of H. pylori positive dyspepsia, if there is a history of use of drugs like NSAID, non-steroidal anti-inflammatory drugs for long time, and also if there is a history of low-dose aspirin for prolonged period, you have to eradicate, you have to give the H. pylori treatment for H. pylori eradication. And last indications for eradication of H. pylori is chronic use of proton pump inhibitor, that is more than, if patient use more than 1 year PPI, then we have to give treatment for eradication of H. pylori. Some extragastric disorders, in some cases we also use eradication of H. pylori. The extragastric conditions are if there is a vitamin B12 deficiency, that is unexplained vitamin B12 deficiency. We know there are many causes of vitamin B12 deficiency, but whenever we cannot find the cause of vitamin B12 deficiency, that is unexplained vitamin B12 deficiency, we can give him treatment for eradication of H. pylori. If patient develops idiopathic ITP, that is idiopathic thrombocytopenic purpura, so this is the important cause for eradication of H. pylori. Another important indications for H. pylori eradication is iron deficiency anemia. We can also use, in case of iron deficiency anemia, H. pylori eradication. So what are the drugs that we use? There are some regime, that is triple therapy and quadruple therapy. Maybe you heard about it, that earlier, triple therapy and quadruple therapy. What are the drug uses in triple therapy? Triple therapy, most commonly drug uses omeprazole 220 mg twice daily, or lansoprazole 30 mg twice daily. Plus we use clarithromycin. Clarithromycin dose is clarithromycin 500 mg twice daily, and metronidazole 500 mg twice daily, or amoxicillin 1 mg twice daily. I repeat again, the triple therapy. Most important thing about the chapter peptic ulcer disease is treatment. And treatment triple therapy is invariably asking question. Whenever you face your Viva board, you may face this such type of question. That what are the drugs that are used in triple therapy? So in triple therapy we use omeprazole. I repeat again, omeprazole 20 milligram or lansoprazole and 30 milligram plus clarithromycin 500 milligram and metronidazole or amoxicillin. What is the duration of triple therapy? The duration of triple therapy usually we use 7 days. In some cases we may use 10 to 14 days, but 7 days is the standard regime. Whatever next, another regime is quadruple therapy. In quadruple therapy we use omeprazole, again proton pump inhibitor, that is omeprazole or lansoprazole. If we use omeprazole, that is 20 milligram, or if we use lansoprazole, that is 30 milligram daily. Now next we use bismuth subsalicylate component 2 tablets 4 times daily, and metronidazole, in that case 250 milligram, we use 250 milligram QDS, or we can use 500 milligram BD, but ideal is to use 250 milligram 4 times daily, and tetracycline 500 milligram 4 times daily. That is the quadruple therapy. We use 4 drugs, that's why it is called quadruple therapy. Whenever we use 3 drugs, that is called triple therapy. So this is the therapy for eradication of H. pylori. Except the drug medication, we have some measures, that is general, we can advise for people for some general measures. What are the general measures? The most important is that is lifestyle changes. What are the lifestyle changes? That is stop smoking. At first you have to say about smoking, because we know that it is the most important cause of gastric ulcer. Around 30% of cases are due to smoking and non-steroidal anti-inflammatory drugs. So you have to advise for stop smoking. After that, you have to advise for avoiding some drug that causes peptic ulcer, disease, or that may aggravate peptic ulcer disease. Drug-induced peptic ulcer disease is now most common cases in urban areas especially. So you have to advise the people about avoiding those drugs that causes ulceration, that is aspirin and non-steroidal anti-inflammatory drug. And in some cases, if patient is alcoholic, or especially in Western country, we saw that alcohol may aggravate the ulceration. So you have to advise for reduce intake of alcohol. This is another important thing. So in general measures, we should advise about smoking, using of various drugs like NSAID and aspirin especially, and alcohol intake. About alcohol intake, he or she must have to reduction his regular alcohol intake. After that, there are some options for surgical treatment. At first I have to say what are the indications for surgical treatment in peptic ulcer therapy, peptic ulcer disease. There are some indications for surgical treatment. What are the emergency indications and some elective indications? What are the emergency indications? The emergency indications of surgical treatment is if there is a perforation, if there is hemorrhage, so you have to go for surgery urgently. And elective indications, some elective indications, like if there is, I have said earlier, there is a gastric outlet obstruction, most common complications. If there is gastric outlet obstruction, then we have to go for surgery. Next one is recurrent ulceration following gastric surgery. If patient developed recurrent ulcer following surgery, then gastric surgery, any kind of gastric surgery, then you have to go for surgical treatment of peptic ulcer disease. And persistence of ulceration despite medication. If we treat the patient with quadruple therapy or triple therapy with 2 or 3 times, after that there is no improvement, then we go for surgical treatment. Now what are the options for surgical treatment? Options for surgical treatments are limited, that is partial. We can do partial gastrectomy, and another option is we can do vagotomy or pyloroplasty. So these are the options for surgical treatment. Now I am going to discuss about the complications. What are the complications of peptic ulcer disease? Later we discussed about the complications. So at first we have to know what are the complications. Why should we give so much importance about the diseases? Why should we treat it earlier? Because of the complications. What are the complications? The most important complications is perforation. perforation. If there is a perforation, we have to do emergency surgery. That's why it is very important. Another important complications is gastric outlet obstruction. It is another indications for surgery. If there is a when we suspect a patient develop gastric outlet obstruction, if there is a projectile vomiting, then we can suspect that patient may develop gastric outlet obstruction. So for that, you have to know the history of the patient. You have to take history carefully, because during taking history, you have to, if patient said about vomiting, you have to ask how is the nature of the vomiting. Is it projectile or not? If it is projectile, then there may be a suspicion of gastric outlet obstruction. And other complications is bleeding. There may be bleeding from GI, gastrointestinal tract. Now after that, we have to discuss, whenever you in your ward you may present a case, there are lots of differential diagnosis about peptic ulcer. So you can differentiate from this condition to peptic ulcer disease. What are that condition? That are chronic cholecystitis. How can you differentiate peptic ulcer disease from chronic cholecystitis? So there are many points. First of all, about the site of pain, nature of pain, periodicity, all points are come. Site of pain in peptic ulcer disease. So I discussed earlier the peptic ulcer disease site of pain is localization into the epigastric region. In case of cholecystitis, it is an important feature that pain for cholecystitis is usually in the right hypochondrium. So site of pain is most important. Whenever you ask the patient, you can differentiate it from the whether it is in the epigastric region or in the right hypochondrium. If patient says that it is in the epigastric region, then you have points in favor of peptic ulcer disease. If patient says that no, it is in the right hypochondrium, then it is in favor of chronic cholecystitis. Other points also included. In case of chronic cholecystitis, patient may be icteric, there may be stool of pale bulky stool or any other any other features. But the important is localization of pain. Another things is next differential diagnosis is chronic pancreatitis. How can we differentiate from chronic pancreatitis to peptic ulcer disease? In case of chronic pancreatitis, pain is localized into the epigastric region, but the important feature is pain may radiate to the back. This is the important feature. So in pain usually taking after food. In case of peptic ulcer disease, pain is related to food, but sometimes there is an empty stomach pain. Pain occur in the empty stomach, or pain usually occur after food, may sometimes occur after. But in pancreatitis, pain is always occurring after taking food, and pain may radiate to the back. Pain is located into the epigastric region, may radiate to the back, and another important thing for pancreatitis is pain is relieved on leaning forward position. So you have to ask patient about the aggravating factor, relieving factor related to the food or not, and localization of the pain. So this point you can, with this point you can differentiate whether it is pancreatic pain, whether it is gallbladder, that is cholecystitis, or whether it is peptic ulcer disease. The most important differential diagnosis. Another important differential diagnosis is non-ulcer dyspepsia. Another gastroesophageal reflux disease. This is also an important differential diagnosis, and irritable bowel syndrome. That is a functional condition of the gastrointestinal tract. So this is an important differential diagnosis for peptic ulcer diseases. Whenever you are going to present a case in your ward, these things are important about you have to differentiate from peptic ulcer disease from such condition. You may ask, in case we usually ask, how can you differentiate it from cholecystitis, how can you differentiate it from pancreatitis, and how can you differentiate it from irritable bowel syndrome. Another most commonly frequently asking question is, what are the treatment options, and how can you treat peptic ulcer disease? This is the most important. These things are important for your case presentation. I think you all understand it. If you understand it, then it is okay. Now we are going to present. Now I am going to discuss about little bit about the complications. That is, what are the complications? In complications, we said that bleeding is the most important complications. What are the bleeding? What is the bleeding? That is upper GI bleeding. So what are the in upper GI bleeding? At first we have to discuss about the common causes of upper GI bleeding. What are the common causes of upper GI bleeding? Upper GI bleeding, the most common cause is peptic ulcer disease. Around 50% of the cases is upper GIT bleeding is due to peptic ulcer disease. Next important cause is gastropathy, that included maybe due to alcohol, some drugs, as I mentioned earlier, aspirin, NSAID, and due to stress. Next one is gastroesophageal varices. So after that, esophagitis, another important cause, and malariostia. This is an important cause for peptic ulcer, so upper GIT bleeding. What are the less common causes of upper GIT bleeding? In less common causes, there is maybe esophageal, gastric or intestinal neoplasm, anticoagulant and fibrinolytic therapy, and there is some arteriovenous malformation if there is a telangiectasias, and some rare causes included vasculitis and connective tissue diseases. There are also maybe connective tissue diseases like pseudoxanthoma, Ehlers-Danlos syndrome, and blood dyskaryosis is also may cause upper GI bleeding. How will you investigate a case of upper GI bleeding? The most important investigation for upper GI bleeding is endoscopy. 90% accurate if we can detect upper GI endoscopy we can detect upper GI bleeding by endoscopy. And sometimes endoscopy is also purpose for some diagnostic or both diagnostic and therapeutic purposes. Another investigations included upper GI barium radiography, and this is all about upper GI bleeding, and bleeding also occur from lower GIT. That is lower GI bleeding. What are the causes of lower GIT bleeding? The lower GI bleeding important causes is anal lesion, that is hemorrhoids, fissures, rectal trauma, proctitis, carcinoma rectum, colitis, ulcerative colitis, Crohn's disease, infectious colitis, ischemic colitis, radiations, all are including colitis, and colonic polyps. It may also causes lower GI bleeding, and colonic carcinoma. Most important cause, colonic carcinoma. It may also causes lower GIT bleeding. Another rare causes of lower GIT bleeding included angiodysplasia, that is vascular ectasia, diverticulosis, intussusceptions, solitary rectal ulcer, blood dyskaryosis, and vasculitis. These are rare causes of lower GIT bleeding. Investigations for lower GIT bleeding included, as we said, for upper GIT bleeding it is endoscopy. So for lower GIT bleeding, the investigation of choice is colonoscopy. Other investigations are arteriography, but it is not usually used. Colonoscopy is the most commonly used investigations for lower GIT bleeding. Bleeding from obscure origin. So sometimes there are you cannot find out the causes of easily find out the causes of bleeding. Some obscure origin of bleeding, or some obscure causes site of bleeding. That is often some small bowels. So small bowels, often bleeding may occur from the small bowels, and in such cases we have to do enteroscopy for diagnosis of obscure bleeding. So I don't want to discuss about the management of bleeding because it is a big chapter and we have to discuss later. So this is all about peptic ulcer disease. I hope you all understand, and if you understand a little bit, then it will be then it will help in your future classes. Hope you all are okay. So this is all about today's class. Hope you all are okay and stay in your home with your family members. Please stay home and maintain all the health instructions. So this is all about today's class. Hope to see you next class, inshallah.